just focus on how the healthcare system is working, or on how the healthcare system is working, or also what are the potential consequences. And what we are doing here today is we try to understand, first of all, how healthcare systems are working in the areas of regulation, financing, and organizing healthcare provision. And also we try to understand what are the potential outcomes, such as access, quality, equity, and also satisfaction with the healthcare systems. But as I said before, with the main focus on health and health inequalities. And this is also what we did in a project I did together, for instance, with Claire Bambra, also with Jason Beckfield, Terje Aikino, and it was a North Face project, and we tried to understand, first of all, how do healthcare systems work, how do welfare states work, and what are their effects. It's at the top, the C, for mortality, and then on D, what is the effects of different types of healthcare systems and welfare states for morbidity. And this also, again, shows it's very important not to only focus on healthcare systems, because the welfare state in general also has a very important impact for your health and for the living conditions of different types of people. So, for instance, if the welfare states reduces the inequality in a certain society, it might be even possible to have a healthcare system that per se does not really reduce inequality, because this part has already been achieved through the welfare state. And so there are many relationships between the welfare state in general and the more specific healthcare systems. So as part of this project with Claire Bambra and Jason Beckfield, we did a typology of healthcare systems. And there we were going beyond the typical way of comparing healthcare systems. In our literature review, we were concentrating on older attempts to categorize healthcare systems, for instance, by Claire Bambra in 2005, where she tried to introduce the concept of decommodification to better understand healthcare systems. And another attempt was done by Boehm and other co-authors, but with a focus, as I said before in the Marmor text, with a focus on actors. And the main question was how different actors have control over financing, provision, and regulation. And they also arrived at different type of healthcare systems. And later at the bottom, you see a formal attempt by myself where I use different indicators: health expenditure, the public-private mix, out-of-pocket funding, and also different indicators for healthcare provision, for better understanding how healthcare systems are functioning, and for better comparing healthcare systems. And this was the starting point for our Words of Healthcare article. And in this article, we were using different indicators based from earlier literature. We had supply indicators, first on health expenditure per capita, then the number of GPs. There are other concepts for using more healthcare provision indicators, which are, in my perspective, however, quite difficult. For instance, if you use hospital beds as an important indicators, and we all certainly agree that hospital beds are an important indicator, but for a very long time, it has been the main focus of health policy makers to reduce the number of hospital beds and to organize hospitals in a different way. So, and this does not must per se a reduction of the level of healthcare provision, even if there are fewer hospitals, but they are used in a different way as before. So our main indicators are GPs, because all patients first of all have to contact, in most countries, a GP before he or she has access to other healthcare providers. Then, in our perspective, the public-private mix in a healthcare system is highly important, because first of all, if the state or other public actors finance a large part of the healthcare system, they also have a huge legitimacy for regulating the healthcare provision and, for instance, achieving more equal access in a certain healthcare system. As a third group of indicators, we have access regulation. Access regulation means how patients have access to the healthcare system. You in Britain have gatekeeping through a general practitioner. In other countries or healthcare systems, you have high freedom of choice and a very low level of regulation. Then another potential of regulating access, as for instance in Switzerland, are co-payments for GP visits and so forth, or other choice restrictions. And then a fourth group of indicators, which are, in my view, quite important. And another scholar who is comparing different healthcare systems, Peter Grunewegen from the Netherlands, is concentrating on primary care. In our view, how a primary care system is organized increases the level, the quality of healthcare provision to a high extent. And so this is the important starting point of any healthcare system. And we have been using indicators on the amount of money invested in outpatient healthcare and also the ratio of GPs versus specialists. And then, and this is certainly the weakest group of indicators we've been using. We try to capture the quality or the performance of different healthcare systems, and we were using some indicators on how about health behavior in different healthcare systems, but this is more a public health indicators. And here, certainly the comparative analysis of healthcare systems can be improved for better introducing performance indicators, for instance, waiting times and so forth, but these were not the indicators we had for a larger number of countries. Then, and this is our main methodological innovation in our comparison. So very often, if scholars use very innovative methods, they use today cluster analysis, but quite often they just run 2 or 3 different cluster analysis. And this is not a good technique really to achieve in the end very precise results. What we were doing is that we were running 24 different cluster analysis with different techniques. And then in the end, we were measuring for all different techniques how often groups of countries were grouped in the same type of healthcare system. And this is what you see here. So we had at the top, we have some first group of countries, for instance, cluster 1 is Austria, Germany, then you also see France, Belgium, and Luxembourg in this group. In cluster 4, you see, for instance, Canada, Denmark, the Netherlands, and the UK. And on the right side in group 6, you see countries from Central Eastern Europe, Hungary, Poland, Slovakia, for instance. And you can also use this for a very strong interpretation of clusters. Then you would even arrive at 9 different types, or at more broader areas with not very strong links between the countries grouped in this cluster. But I will explain this method and the results in particular in more detail now. So what we arrived at are more or less 5 different types of healthcare systems. So on the bottom right, you see one type of healthcare system where private financing plays a great role, also market competition. It's the United States and Switzerland, and they have no link, even not weaker links, to any other type of healthcare systems. In particular for Switzerland, it's quite surprising. It has started as a kind of social insurance type, but more and more privatized. So private insurance agencies are responsible, and also healthcare provision is more privatized than in any other European healthcare systems. And there are no links to the neighbor social insurance countries like Germany, France, or Austria. Then on the top right, you see the group of Central Eastern European healthcare systems like Poland, Hungary, and Slovakia, with very strong links and only very weak links to other countries or types of countries. The third group, where also the UK is included in our typology, is a group where there are very strong links between the Netherlands, Denmark, and Canada, but also quite strong links to the UK and to South European countries, Italy and Spain. Through the UK, but not through any other country, there are also links to a fourth type of healthcare systems with Sweden and the other countries, Norway and Finland, being at the center, but also with strong relationships and strong links to New Zealand, Portugal, also to Asian countries, Japan and Korea. And then we have a more heterogeneous cluster at the bottom left, with very strong links between the old traditional social insurance type countries, Germany at the center, Belgium, Luxembourg, Austria and France, but also with strong relationships to Ireland, for instance, Australia, Iceland, and to other Central Eastern European countries, the Czech Republic and Slovenia. And just to, or in my understanding, the typology is not just to distinguish countries from each other, but to better characterize them and to better explain how are they organized, how do they work, and what are their advantages or disadvantages. And here you see that in the first type of countries with Germany, Austria, France, for instance, you have a very high or you have a high level of health expenditure and also a very high level of healthcare services, not only GPs, but also other services. And during the Corona crisis, you were also able to see that in some of these countries, Germany and Austria, for instance, there are still is a very high level of hospital beds and also of intensive care units, for instance. Also, the public financing is quite high in these countries, and what I consider to be of great importance, the specialists. And there are a lot of specialists outside the hospital working in outpatient care. They are mainly paid fee for service. And the way of remuneration has a huge impact on how services are provided. So if people, in particular outside the hospital, are paid fee for service, they have a huge incentive to increase the level of service provided. And when there is also a freedom of choice, they also have a huge incentive to provide high quality, because otherwise patients might change to another service provider. And this is also the case in these type of systems in Germany, in France, in Austria, for instance, in Belgium. So there's very low access regulations of patients to service providers. So there is in principle a very low level of gatekeeping, and there is a very low restriction of choice. at the cost, however, of the level of healthcare financing. So these healthcare systems and also the freedom of choice make these healthcare systems quite expensive. The primary care orientation and also prevention is low, and the quality is, with our indicators, more on a medium level. Then the second group and second type of healthcare systems, and here, for instance, Sweden, Norway is part of this group. Expenditure is lower, and also the level of healthcare services are lower than in the first type. Public financing also is quite high, and the remuneration, and this changes the incentives, in particular of specialists in the healthcare system, is mainly based on a salary. Access regulation is much lower. There is a higher restriction of patients' choice, and the primary care orientation and in particular prevention is much higher compared to countries from Germany or Austria. Then in the third type of healthcare system, sorry, I just have to check my PowerPoints. So the PowerPoints were not working, so I hope that it's now, yeah, now it's going again. So the third type of healthcare system is quite similar. So there are countries like Denmark, also the UK, Canada included, also the Netherlands. Level of expenditure and healthcare services are quite similar as it is the case in Sweden and Norway and other countries. Also, remuneration is mainly based on the salary, but access regulation is even higher in these countries. And also the restriction of patient choice, although I know that in England you try to improve choice of doctors, is quite, compared to Germany, Austria, and France, much more restricted. Primary care orientation is at a medium level, and prevention is a bit lower than it is the case in Sweden, Norway, or Finland. Then in the fourth type, these are countries from Central and Eastern Europe. Well, basically everything is low. They have fee for service, but if there are high incentives, but there is only little money available, it has not the same effect that this principle of remuneration has in Germany, or also Switzerland or the United States, on the increase of service provision. And then the last type is just the two systems of the United States and in Switzerland. Here we have high expenditure, but they buy with high expenditure only a modest level of healthcare provision. And then interestingly, they also have free access and higher choice than in most other countries, but also prevention is higher than it is, for instance, in Germany or Austria or France. So when we now come back to the 5 types in our network analysis, I try to explain to you that in my view, this is based on a certain development that starts with certain values that have been implemented in the respective countries. So in countries like Germany or also Austria, France, the idea of security, of social security, was of highest importance when these kind of healthcare systems started to develop. And because the high notion of social security, the respective actors like doctors' associations, in Germany we call them panel doctors' associations, achieved a very important role and were able to achieve a high level of healthcare service at the cost of also high expenditure. And if you try to achieve for patients a high level and easy access, you have to introduce low access regulation and high level of choice. And at the same time, prevention and primary care is at much lower importance as it is in other types of countries. And this, in my perspective, is in huge contrast to countries or healthcare systems, for instance, as we have it in the Nordic countries, in Sweden, for instance, where the focus or the value of equality, so equal access, is much more important than it is in Germany or France. The idea of social security, so that you need good healthcare provision when you are in need, is also relevant, but equality is also a value that has been important from the very beginning in this type of healthcare systems. So here we have much more equal access, while in Germany we have distinguished between private insurance patients and social insurance covered patients, and you have different levels of access for both types of patients. This is not the case in countries like Sweden. If the main idea is equality, then you have a much higher legitimacy to regulate access and choice, because when you regulate access and choice, as I will show later, then you achieve much more equal access between different groups of people. And then you're also able to restrict the resources. So these types of healthcare systems are not as costly as we have in the first group of healthcare systems. What we have in the UK, also in other countries of this cluster, is quite similar to what we find in Sweden, but we have even stronger access regulation, lower prevention, and what has not been part of our study, but what is, and we also see it now during the Corona crisis, is of huge importance. We have a much lower importance of local authorities. So in all the other Nordic countries, which are in many respects quite similar to what we find in the UK, but also Italy or Spain, have a much lower role of local authorities. And so while in Norway, Sweden, and Denmark, local authorities have been quite successful for combining elements of the healthcare system, of social care, of public health measures. This has not been the case in the UK, and in particular not in the Southern European systems. While in the United States, for instance, there's another value of high importance. Here we have also the notion of security, but also a much higher importance and emphasis of individual freedom. And again, this has in the long run a huge effect on how healthcare systems are organized. I now come in the second step to how the focus on healthcare systems, in part also of welfare state, can be combined with the analysis of health inequalities. I said in the beginning that this is quite difficult, but there are some first studies that can serve as a starting point. Here we have a study by Rüdland and others, also Claire Bamba, I, and Johann Mackenbach have been part of this group. And here we have been using a similar typology as I introduced right now. And we analyzed health inequalities in different groups of countries. I will not here go too much into detail, but just show to you one first result of this type of study. And here you see absolute inequalities, health inequalities of men and women. And you see that in both groups, countries like Sweden, were at the top, where also prevention plays a strong role. And then countries, also including the Nordic countries, follow. England is also there with a quite low level of inequality, but with more variation as it is the case in other countries. And then in the middle, you see countries like France. Germany has not been part of the study, but it's quite, should be quite close to Belgium or France. And at the bottom, you have countries from Eastern Europe with much lower level of health care provision. Well, the path or the mechanisms through which healthcare systems can have an impact on health inequalities is in particular.
What? Oh no!
Sorry, Claus, do you want to continue?
Sure. As you all certainly, I heard some noise from other participants. So one way of trying to show the potential impact of healthcare systems on health inequalities is through analyzing how the access for patients to healthcare providers is regulated. And again, here I just want to show you one result of this study. Here you see at the x-axis the legal regulation index, so from left to right, the regulation of access to the healthcare system is increasing. So with very high access regulation in Denmark, for instance, also in Spain and the Netherlands, also in Finland. And on the left, you have countries with free choice and very low level of access regulation like France, Germany, and Belgium. And then on the other axis, you see the inequality of visiting a specialist when controlling for all other factors like health needs, age, and multimorbidity, and so forth. And what you see here is that there is strong correlation between having strong access regulation through gatekeeping, as we have it in the Netherlands. In Denmark, for instance, the UK is not part of the study, and we have much higher inequality when controlling for all other factors in countries like France, Germany, or Belgium. Italy at the top right might be an exception, and this there is high regulation in the overall healthcare system, and that we also see here a huge inequality between the access of different population groups when visiting a specialist is certainly related to the huge inequality between North and South Italy, what we were not able to control in this particular study. And another study we did on the consequence of different types of healthcare systems is analyzing confidence or trust in the healthcare system. Here, the focus is on people's confidence in receiving medical care when being seriously ill. And these data come from the Commonwealth Fund study. It's a 7-country comparison. And our starting point was whether people made the experience of not going to the doctor, although they were in need because of costs. And here, what you see here in this PowerPoint is that on the left side, and all these 3 countries belong to a certain type of healthcare system with access regulation and high level prevention and high level of primary healthcare. And there people at that time, at least, they hardly experience any access problems when because of cost when visiting a doctor. Germany, every 7th patient has made the experience that because of cost of co-payments, for instance, they decided not going to the doctor because of cost. And the highest value is in the United States, with every fourth patients made the decision of not going to the doctor, although they needed medical treatment. And our second step in this study was how this had an effect on people's trust in the overall healthcare system and in people's confidence. And what we also see now in the corona crisis, we also need to trust the healthcare system. And if people do not trust, they do not behave in a certain way, and they do not support the healthcare system. And for instance, in Germany, people have lost trust in healthcare politicians and in the healthcare system in more recent time. And this is what we see, for instance, in health behavior when it comes to vaccination at the moment. So the idea of trust is certainly of high importance. What we saw in this study, where we measured in the second step the confidence in receiving medical care when being seriously ill, we see that many other factors also have an effect. So income, for instance, have an effect. So the level of income increase or reduces the confidence in receiving medical care. And in particular, if you have a higher income, you trust more that you will receive good care. And also the health status has an effect, but the strongest effect we measured were that when people were making the experience of not going to the doctor when being ill. And the more overall conclusion is that we have to reduce these excess problems and have to reduce private co-payments, for instance, because even in minor situations, when people make the experience of not going to the doctor because of cost, they lose confidence and trust in the overall healthcare systems. So these are just few examples of how healthcare systems analysis can be combined with a kind of outcome analysis. And this is also now already starting when we focus on COVID-19. Again, I will just discuss one first study by Claire Bambra and other co-authors, and they focus in this study only on health inequalities. So their argument is that during the pandemic, all health inequalities we experience since a long time in European countries have even increased during the corona crisis, and because of the consequences of the crisis, so that in the long run, we will even have lower resources for our healthcare systems and for our social policies. These social and health inequalities will even increase. And this is what we experience already in the United Kingdom and also in the United States, and that in many other European countries as well, health inequalities are already increasing. In my last point, I would like to come back to the typology and potential consequences in different types of healthcare systems during the corona crisis. So here we have again our typology, and when we try to understand how different types of healthcare systems were responding to the corona crisis, we were concentrating on intensive care units, for instance. And in Germany, in France, in other countries, there are much more intensive care units than in many other countries. And for instance, the president of our doctor associations here in Germany, his first argument was in the very beginning that now countries like Denmark or Sweden will pay the bill because they reduce the number of hospital beds too much. But we did not experience that in the Nordic countries, at least. In other countries, it was the case that the number of intensive care units were too low. And my argument is that the reason is that, in particular in these countries, in Sweden, in Denmark, also Norway, in Finland, they are much more flexible, and many parts of the healthcare systems is organized at the local level with a very strong position of the local authorities, and they were quite flexible and had the administrative power to, in a very short time, to increase again the number of hospital beds and also of intensive care units. In the southern European countries, in Italy and Spain in particular, which are in many respects organized in a very similar way, they were not able, because they had not the administrative power, to increase hospital beds and intensive care units in a very short time. In my view, the UK is in between. It's not as good as it is in the Nordic countries, but it's also not as poor as it is in Southern Europe. The United States is a special case. Here, from the potential, the intensive care units must be very much higher. But in contrast to Germany and Austria, because of the huge competition between hospitals in the United States, it has not been worth to have a very high level of hospital beds in the United States, and they had not the capacity to increase the beds in a short time, as it has been the case in Sweden, in Denmark, Finland, and Norway. So here I'm at the end of what I wanted to share with you. Only part of the story is hopefully, but in the end, answered. So the focus on healthcare systems and their potential to analyze healthcare systems. And so I wonder what your main questions are regarding the combination of health care systems and health inequalities.
Okay, well, thanks very much, Claus. As I said at the beginning, what we'll try to do is go through the chats. In the default will be sequential order, but obviously if there's any themes, we'll try to keep themes. So I'm sure Jenny will sort of keep me on track if I miss anything. But my reading is the first couple of, this goes back a while, but we had two surprising reactions, roughly I think on the same thing. First from Mark, and secondly from Jonathan. So if people are happy, what I'm going to ask people to do is if they're happy to unmute themselves and ask their own questions. So we'll go first to Mark, if that's okay with you, and then to Jonathan.
Yeah, hi, thanks Claus, very interesting overall. I was interested though in the table that you had comparing different health systems. I think it was about a table of 7 different columns. And the last one was USA, and you had put primary care orientation down as one of your criteria. And you'd put in for the USA, Switzerland high for that. And I was just referring back to Barbara Starfield's work on the primary care as a measure for overall health system, at least macro efficiency in terms of global health budgets. And so I was just wondering if you could explain or clarify what you meant by primary care orientation. There was a lot of material, so I'm not surprised you didn't cover everything, but on that point, that seemed to be a bit of a standout to me. And I think also Jonathan had that as well.
I'd echo that. A number of spheres where you're running counterintuitively. So you said low access. Well, actually, Americans famously have very high access, partly because they don't need primary care. They just go straight to the specialist. They're not terribly good at prevention, hence their poorer figures on things like antenatal care and so on. So I'm just wondering how you managed to get those figures, and perhaps just explain them as Mark was saying.
Yeah, thank you. Well, for the primary care orientation and certainly the difference of the result of different studies certainly are related to the different use of certain indicators. And our indicators we were able to include in our analysis was the share of financing in outpatient healthcare. So this was interpreted by us as primary care orientation if a higher amount is invested outside the hospital, and then the share of specialists versus general practitioners. And it's only one possible indicators. And if I would focus on how primary care systems work, as for instance Peter Grönebecher is doing it, I would certainly include other indicators. One reason why in particular Switzerland, but also in part the United States, are based on these indicators, investing more money in primary health care is related to the incentives. So in both countries, patients or insured people, so it's mainly based on private insurance, also in Switzerland, and people can choose if they reduce their premiums by having, first of all, higher level of access regulation, and also for designing for a primary care doctor. And so our argument is, although both countries certainly have not developed in a kind of primary care role model, through the financial incentives as part of their insurance premiums, more people have decided for these kind of primary care systems compared in particular to Germany and France.
Sorry, can I just come back on that? Because it strikes me that spending money, there are an awful lot of other variables than just patient access. And I just wonder whether utilization might give you a better index of primary care focus.
Right, yes. And so one reason why we did not use utilization indicators is that with our typology, we wanted in particular do this kind of studies in a second step. So compare different types based on the indicators we have been using and what are the potential effects of how these healthcare systems are organized on utilization. And you're right, it could easily be that in the end, or my expectation is that in particular in the United States and in Switzerland, although based on our indicators, primary care is stronger, at least as it is in Germany and France, the utilization of primary care is not as high as in the Nordic countries or the UK. But to better do these kind of outcome analysis, we didn't include utilization or health indicators in our typology.
Okay. Just to show I'm going to do what I said I'm going to do, I'm going to give up on my own question for the moment because we've got a question from Jennifer that's related to that theme. So I'm going to ask Jennifer to give a question next. And if no one else new wants to ask a question, I'll go to Jonathan's other question. So Jennifer first, please.
Thank you. Yeah, I just wanted to come in on this because I'm a US primary care physician now practicing as a GP in the UK and also a health services researcher about access. And I just wanted to counter from my own experiences and research the notion that some people have expressed about the US not being a primary care-oriented healthcare system. I mean, certainly I'm aware of the shortcomings of the US healthcare system and the fact that certain people are completely denied access to it. But actually, it is a healthcare system very much oriented to primary care. And actually, it's incentivized in a lot of ways for the primary care physicians to provide more comprehensive primary care, more coordinated primary care, and include preventive care within primary care. So most of the people who have the two major health, federally and state insurances, Medicare and Medicaid, those systems are constructed to completely go through primary care. And then similarly, most of the private insurance that's people who are employed have through their employers. As Claus explained, a lot of those, you can occasionally choose to have something that bypasses primary care as kind of an option, but that's sort of maybe the same, not quite fringe, but it's only one part of it. And most people opt for the more standard one where you go to primary care and you always have a named physician, which this country has given away the individual continuity thing, you know, in some previous iterations of policy. And individual continuity is something that's been difficult to carve back in and to prove that it's important here. So I think practicing in both countries, I actually feel in a lot of ways within a healthcare system, the US is strangely, so way of a big surprise to me, is somewhat more primary care oriented. And so I just thought I'd share that.
Well, thank you very much. Well, this is very difficult. Normally, I would just answer in a way that I basically agree with you. That one part of the understanding is, well, in the United States, well, in Europe on the other side. In Europe, we have, say, 4, 5, maybe even 6 different types of healthcare systems that work in a very different way. And we just use the United States, it's one unit, as one healthcare system, but in the end it is not. And certainly if we just distinguish the United States and try to understand how these different types of healthcare systems with veterans healthcare, with Medicare, Medicaid work, and they work as separate systems, and they work in different states in a different way. And so certainly we had then to focus on these different types within the United States, and there we certainly would identify very strong primary healthcare systems and very weak ones. And in particular for those who have no or hardly any access and they have to go to the emergency care units, they hardly have this experience of good and well-functioning primary care. But I also want to answer you in another way, and this is more kind of disagreement. I think from my long discussions with other healthcare system analysts from the United States that in the end, there are some units that work on a very high level in the United States. And I know in particular in the Commonwealth Fund, they focus on making very strong primary care systems, and some of them achieved. But in the end, because there are so many actors trying to pour money out of the system, there's so little money really coming to where the patients really need it, that this competition and the huge level of privatization in particular weakens primary care, and that at the bottom, many doctors do not make decisions as they do in Denmark. In Denmark, for instance, there are dental clinics at the local level. They are financed by local authorities, and they really provide services to the patients, not because they earn money out of it, but because they want to treat the people and the patients. And in the United States, I think the idea of money making and competition is for a real primary care system too weak.
Okay, being as we haven't got anyone else new asking a question, what I'm proposing now is they've made points in the chat that related to this current debate. So I suggest that I give Mark and then Jonathan another comeback on partly what they said earlier. And then I'll go to myself if there are no other new questions. So first of all, Mark, please, then Jonathan again on the points that you made.
Yeah, it was only just an interesting discussion point building on Jennifer's, because I thought, I think there are some signs that the primary care has developed in the US. Whether we are comparing like with like, as Claus has said, in terms of outpatients departments, a question. But I think Barbara Starfield's work about linking global healthcare costs and the strength of primary care being inversely related, I think is quite strong. So if we do see some change in the US, then I think, and yet we still see some relatively high costs in the US, very high costs, that would perhaps lead to some sort of reassessment of the Starfield thesis, which would be interesting.
Claus, you nod into that. So I've got a question from Stephen, but if we go to Jonathan first and then Stephen.
Once again, I'm just echoing Mark, I think, and I don't pretend to be up to date on this. I come from Starfield's era, but the sense is that the culture of general practice is very different from the culture of primary care in the States, and I'll stand to be corrected, which is much more holistic and people-centered rather than disease-centered. And my sense in the States is that the primary care physician is a watered-down secondary care physician. Sorry, Jennifer, come back at me. And that leads to high costs and high investigation rates and a very different model to the one that we have here.
Yeah, well, as I said, in principle, I agree, and sorry about that. In principle, I agree, and for really understanding the what we can achieve with primary care, we certainly have to go beyond the indicators I've been using, and besides the kind of typology, which is, in my view, in particular interesting for doing certain analysis with a larger number of countries for analyzing certain effects, certain outcome effects. But if I really want to understand how a primary care system is working, I would reduce the number of countries, and in particular have studied in particular countries like Denmark and Sweden, also the UK and in Germany. This was a comparison I started with. So there, I think it's so important really to understand not only the role of certain doctors and how they provide the services, and not only what I try to understand how the concept of gatekeeping is working and how patients are guided through the healthcare system to other providers. Another aspect which is of increasing importance is the communication. And communication means, for instance, the digitalization of healthcare system. Again, some parts of the United States are quite strong in this process, and some hospitals and primary care centers are quite strong and others are not. But the only very strong centers where hospitals, primary care, and also public healthcare centers are very closely collaborating. This is what I find, for instance, in the Nordic countries. So it always depends how these centers are related to other institutions from social policy, but also outside social policy. So social care, for instance, is of huge importance, as we see, for instance, at the moment during the Corona crisis.
I think Jennifer has added another point. So do you want to make that point, which seems to be on the same thing, before we move to Stephen?
Yeah, and I don't want to detract too much from the presentation and the core of it, but just that I don't think that anything that I'm saying undermines Starfield's conclusions. I'm reminding that the complete denial of access to care, so the lack of universality of access to primary care in the US is a major structural problem. But where care exists, where people have insurance, where healthcare system exists, and it's difficult to study and because there are so many different models, but by and large, because I've worked in the VA, I've worked in federally qualified health centers, I've worked in university hospital systems, primary care is generally, I would say, more comprehensive, certainly more whole-centered. We'd never dream of a one problem 10-minute appointment. It would just not fit what our patients have. We deal with multimorbidity. We have an unhealthy population, you know, and when I came here and had to prove all my credentials, they said I went too slow because we have longer appointments with more problems dealt with on each one. It's making me feel like I should do a research study to show this because the misconceptions about the thing about the US healthcare system is you just can't generalize it because there's so much heterogeneity, but I think the misconceptions about what care actually looks like often leads us also to the problem of people parachuting in, seeing something working and trying to bring it back to the UK, whereas actually we're just, you know, coming from a different place, and often people misconstrue what they see and the reasons for why it's different. I think things are different because And actually, we have more comprehensive primary care for those who are lucky enough to have it.
Just to answer you with another example, so in Germany or Austria or in France, we still have in the primary care field, a majority of the services are provided in single-handed practices. So there, in my view, the main concept of primary care, where people collaborate and where people with multimorbidities, for instance, can treat it in a much better way by different types of service providers, different specialties. This is not really working in countries like Germany, France, Belgium, and also Austria. And there, I think in the United States, but also in the United Kingdom and in the Nordic countries, the idea of developing larger primary care centers where people have shorter distances because more and more people are multimorbid and they need different types of service providers. Short distances are key, and they need diagnosis from different service providers. So I think there, the development of primary care orientation is in all these countries much more improved as it is in the other types of healthcare systems I have presented, in particular in the first type with high expenditure, high service provision. Good results during the Corona crisis because of a well-developed hospital sector, but with much lower experiences in primary care. In the United States, well, again, in some areas, certainly we have these level of very strong primary care units. In another study we did, we measured that in particular medic aid patients have very poor access to all areas, including primary care of the healthcare system. In principle, from the regulatory side, they should have not. But because many service providers seem not to accept medic aid patients, or they have to travel longer distances, there seem to be a lower access not only to hospital care, but also to primary care for these type of systems. So, but in principle, I agree. Primary care is developing in some parts, but the main problems of the US healthcare systems are on a larger scale with too costly services, with too little access for important population groups.
Okay, thanks, Claus. Stephen, you asked a while ago 2 questions, if I may, and it's been, yes, of course you may. So please go ahead with your 2 questions.
It was really just to say, Jennifer, I recognize what you're saying in terms of your experience in the US and the States, because I'm from Canada, and I was born and raised there and lived there till I was in my 30s, and I'm a nurse, and I came here and I work in the UK in the NHS, and as I say, my background is in nursing. And so my question for Claus is, this is a very interesting conversation about costs and how the systems operate, how primary care works, and then how that spills over into secondary and tertiary care and so on. The question for me is about gatekeeping, because all systems have to gatekeep. There isn't an unlimited amount of resource available for healthcare. So in terms of the NHS, we rely on primary care to help do some of that gatekeeping. And for social care, we of course rely on the local authority means test to weed out those who can afford to pay. So both systems in the UK means test. And I'm just wondering, across the other countries you've looked at, and I have some experience, of course, in Canada and Jennifer in the US, but in terms of how health and social care interact, which is very different. So here in the UK, we often have this issue between what we say in the NHS is social care dumping on health and vice versa to control costs. So I'm wondering about the interplay in your research, if there is some you've touched on, in terms of the interplay between gatekeeping and social care, healthcare. And if I could pause, Martin, just to throw in my second question, if it's possible, to talk about integrated care systems. Our chief exec, Simon Stevens, is very enthusiastic about healthcare, about integrated care systems. He has a lot of experience working with systems and companies in the US, care system companies in the US. So I'm just wondering if you could comment a bit on integrated healthcare systems, what you might be able to shed any light on in terms of our discussion about costs and gatekeeping.
Well, again, it's a very complex question with many, many different areas touched, and also a very interesting one. I try to answer it in two, maybe even more ways. I consider gatekeeping, or in particular, one actor which might be the general practitioner or a primary care unit, where other services are connected and which improves the communication between other service providers, including social care, also including public health measures, is of key importance. And you have it, as I know, in Canada, also in the UK, and in a number of other countries, but not in our countries. For instance, in the many European countries, in Germany, France, we do not have this kind of gatekeeper. We have certain kinds of restrictions, but not a gatekeeper. And we have so not a certain actor which leads patients through the healthcare systems, from the hospital to social care units and so forth. And this is, and here I absolutely agree with you, this is what is important, exactly is needed. So we need better communication through digitalization, but also certain actors who is leading and guiding patients through the healthcare systems, including social care. As I said, this is better developed in a number of countries, but not in Germany or France or Austria. There we have this kind of services in connection developed on a very poor level.
Okay. I've not been notified of any new questions, so I think Jonathan has something on polyclinics. Do you want to say something briefly on that?
I'm sorry, I don't mean to.
No, there's no one else, Jonathan, please. If it was somebody else, I would stop you, but there isn't, so please go ahead.
It was really a passing phrase by Claus about the primary care getting bigger and bigger, and the model that it's almost aspiring to is the polyclinic, which is actually like outpatients. It doesn't do what primary care does, or what, in my view, primary care should do, and the sort of thing that Jennifer's been talking about. So again, there's a balance, I think, between developing economy of scale and getting larger, but losing the small is beautiful idea of being patient focused rather than throughput focused, which is what tends to happen in larger clinics.
Well, if I understood you correctly, I would say these units to develop in a direction that at least has certain capacities. And these Danish units, for instance, were quite powerful during the Corona crisis. They were established at the places of former hospitals. So they reduced, in Denmark and other Nordic countries, the number of hospitals to a high extent, and they introduced huge hospital centers. I think now there are only a very few, but very large hospital centers all over Denmark. And in other former hospitals, they established what you call the old East German way or socialist way of organizing polyclinics. And these units, in Denmark at least, were even able to introduce what they had before, acute hospitals and also intensive care units. So they are quite flexible, and they were able to respond in this particular crisis. And this is what I think is in particular needed, but not on the basis of competition, on profit making, but on public regulation. Because when they these kind of services have the capacities for increasing intensive care in a very short time, this is very, very costly. And in a competitive world, these units would never do it. So this is why we don't have these kind of capacities in this way, at least in the United States, but we have it in the Nordic country with much stronger regulation. I do not mean it in the absolute number of how large it is, but on the capacities, what they can do when it is needed.
Okay, well, I'm afraid you've all got yourselves to blame for this, but as being as I haven't been notified of any new questions, we're back a long way to the question I put in the chat a long time ago on a completely different subject. Claus, it goes back to that, I think figure 2 you gave, which was almost a sort of regression equation type of thing, which you had a line and one of the axes was legal regulation, legal protection, and the other one was probabilities. And you had roughly the same level of legal protection, if I've read the graph right, a very different, very large positive outlier and a very large negative outlier. I think one was Italy, the other one was Spain. Any thoughts on, have I read that right? And if so, what are the reasons for that?
Well, I just got the point that we measured different levels of legal regulation. Here, I just, as a first step, I just want to explain how we measured it. So we used not only is there gatekeeping or not, but also how long, for instance, do patients sign in at the practice of a certain general practitioner, whether there is, as it is in Denmark, the choice of general practitioners once a year, whether it's restricted to a certain region, which is not the case in other countries, but in Denmark. Then we also included in this legal regulation index whether people have a choice of specialists. And when they have a choice of specialists, do they first need a certificate from the primary care provision, or can they go directly to the specialist in outpatient or inpatient care units? And then we did the same in hospitals, because also there are outpatient care units in hospitals, and whether people have direct access and choice. And all these indicators we used from the healthcare system in transition series from the European Observatory of Healthcare System, which was quite demanding to find and collect all these indicators. We developed this access regulation index. And this is what we show in this figure. And then we did a multi-level analysis, and we try to understand how these different levels of legal regulation have an impact on the probability of visiting a specialist or not, with indicators from the share data from the Survey of Health, Aging and Retirement. So this is why, and in this share wave, the UK was not included. This is why we don't have UK data. And then I think you mentioned that there are countries at the bottom. Here we just don't measure differences between population groups. This is connected in our interpretation to the very strong level of regulation. On the other side, and I think this was Switzerland, for instance, we have freedom of choice, very low level of regulation. And here there is certainly another weakness of doing this kind of comparative studies. It's very complicated. And here, Italy on the one side and Switzerland on the other side is certainly one of the countries where we need to dig deeper and try to identify more indicators why they are on this side of the scale and not on the other. For Switzerland, for instance, we just used the national indicators. But as I said before, people, and they increasingly do it, can individually decide for a private insurance premium that restrict the choice. So in principle, from the national regulation, there is little restriction, but from the individual decision of the individual patient, there is high restriction. And this is certainly one potential why we came to this placement of Switzerland on the bottom left.
Okay, thanks very much. I haven't been notified of any new questions. Now that might be because people are very keen to get this sort of 5 or 10 minutes gap between the next Zoom meeting. It's like those precious 5 minutes. So last opportunity. It's almost like an auctioneer with a hammer. Hammer's going down in a second. Okay, I think Francis is saying have to leave. I don't know if that's a comment, Francis, or whether you'd want to say something, whether you have left or whether you want to make a comment. No, I think that was a sorry, I have to leave message. Okay, well, if there's nothing else, I'd like to say thanks very much to Claus for a fascinating seminar, and thanks to you all for attending. And Jenny, I'm putting you on the spot now, but you're probably more likely to remember than me. When is our next HSMC seminar? Sorry about that.
So it's the 23rd of March with Tuba Agartan.
And it's on health, global, universal
policies on healthcare across borders. Yeah, healthcare across borders.
Okay,
politics
so
and policies therein.
The main program, we even had an advert for the next one. So thank you very all much for attending. I hope to see at least some of you perhaps for the next one. And again, just thanks to Claus, and thank you to everybody.
All right, thank you for having me here, and hopefully see you again. Bye.
Okay, bye then. Is there anything we need to say, Jenny, or is that so we can pick it up again?